the Norfolk and Waveney Clinical Commissioning Group. My name is Dr. Anoop Desi, and I'll be chairing the meeting today. This meeting is not being broadcast, but it is being recorded, and it'll be available to watch on the CCG website after the meeting today. There are members of public who've been asked and who wanted to join the meeting, and they'll be watching this meeting live. We'd be grateful if members of the public can turn off their microphones and cameras during the meeting, please. There is an opportunity for members of the public who are watching the meeting to ask questions about any items on the agenda or to ask for clarification if they're uncertain of anything that's being discussed at the meeting. This can be done by raising your hand at the slot at the end of the meeting for questions, or raising your hands if I invite you to ask any questions during the item by myself. Members of the public can raise questions by email during the meeting. They should be sent to nwccg.communications@nhs.net. If the question relates to an agenda item, then this will be read out at the end of the meeting. The governing body will either answer the question or defer the answer, in which case a response will be prepared in writing within 7 days and sent to the requester and published on our website. Just a reminder that this is a meeting of the CCG which we're holding in public as best we can, but it's not a public meeting, so any questions that are not related to the agenda items will be answered and displayed on our website, but won't be read out during the meeting. Finally, as it's being recorded and the meeting will be in the public domain, members of the public are asked to refrain from sharing any personal information or information relating to third persons when raising any questions or asking for clarification regarding items on the agenda. Okay, so thank you. So let's make a start. If you can have your papers in front of you, and we have got quite a long agenda and got quite a lot to get through. So I will have a short comfort break for 5 minutes at the beginning, at the middle. And we do need to, as much as we can, keep to time. Otherwise, we won't be able to get through the agenda in a timely fashion. So apologies. Well, first of all, any chair's action. There was one item of action which we discussed at the last meeting, which was the signing of the annual report and accounts, which I did under chair's action with advice and support from our lay member responsible for audit. So that was signed off under chair's action. Apologies, item 2, we've had apologies from Dr. Arden Ross for this meeting and from Dr. Hilary Byrne. I think otherwise everybody's here currently, but I've been made aware by Rob that he will have to leave the meeting. Rob Bennett will have to leave the meeting for a short while, but we'll make a note of that when that happens. Were there any other apologies for the meeting, or is everybody else here?
No further apologies, Chair. Okay,
thanks, Karen. Declarations of interest, item 3. So just a reminder, first of all, that the register is kept up to date in terms of your interests, and also if there are any interests that might where you might be conflicted that are on the agenda item, if you can either make me aware now or as the item is being discussed, if you could make me aware at the time if there is a conflict of interest or what might be perceived to be a conflict of interest. Okay. Yeah, Peter.
I've already notified the CCG that I'm on the waiting list for a procedure. So I know waiting lists are coming up. So that's a new declaration of interest.
Oh, thank you for that. Okay, let's move to item 4 then, which is to approve the minutes of the previous meeting, which was held in public on the 25th of May. That was a meeting, Mark, that you kindly chaired in my absence. So shall I'll take that as a whole in terms of accuracy. Are there any items there of accuracy that people want to comment on? Yep, John.
Yeah, thank you, Chair. Just one item on the very last page under any other business. And the main paragraph there just talks about some of the priorities from capital, and the figure next to the Queen Elizabeth Hospital says 2.5 million. That should have been 2 million.
Okay.
Thank you.
We'll make that correction. And any matters arising that we're not covering on the agenda today from the last meeting? No. Was there anything you wanted to add, Mark? Because you chaired that meeting for me kindly.
No, thanks, Anoop. I looked at the minutes and was happy with them. Thank you.
That's great. Thank you. Item 5, the action log. I think there were just a couple of items which are the due date is today. Item 15 is complete. Well, if we go from the top, the governance handbook is complete and closed. The flu programme, I think we're getting an update which we're sharing today, so that's in progress. There were a couple of items on the assurance framework. I think it's Kath, has I got your name or Karen's name next to it? Are those?
Yeah, that's the Chair. That'll be brought to the August meeting.
Yeah. Okay. And then the update from the clinical executive, and I think we're having that today, so that's completed, and we're on track for that. Okay. So item 6 is Melanie's report. So Melanie, over to you.
Thank you very much, Chair, and good afternoon, everyone. I was just, by way of introduction for my report, I wanted to just share a few reflections on actually the items that we've got on the agenda, as well as some of the issues which I've talked about in my report. And I think there's a really important thread throughout the agenda today around innovation and also inclusion, both inclusion in terms of inclusion for us as an employer of our staff, and also inclusion in terms of the business that we have here and serving the public. And I'm really pleased to see the item on the agenda around values, where actually CCG staff are voting for those two of those things, innovation and inclusion, to be part of our core values. And so again, just to highlight some issues in my report which are relevant to both of those things, I think I wanted to just highlight the East of England anti-racism launch, which I was very delighted to attend, along with other colleagues. Anna Morgan also attended too, and this is something that is very, very important to me on a personal level, and also in my role here as the leader in within the health system. I've made my pledge to anti-racism. I know other colleagues have as well, and we are holding a more dedicated full staff briefing around the anti-racism launch, the anti-racism strategy in a few weeks. And this is a conversation that we will continue to promote and encourage, so that staff can feel included and the public can feel included, and that the NHS and Norfolk and Waveney CCG do not tolerate racism of any form. So that was very important moment. Wanted to also just mention the immense pressure in the system, which in my report I've talked about some of the visits that I've made to staff working in hospitals and in general practice, and even since writing the report, the pressure has just increased significantly on staff, which we have an agenda item on pressure in the system later on. But with that often comes at times a lack of kindness and a lack of warmth. And I think we're also seeing this, it's in some ways understandable given the pressures within society, but it's very real within the NHS at the moment. And, you know, reminding ourselves as leaders, I think, of caring and compassionate leadership, but also just, you know, really to value and acknowledge the work that our staff, all of us are doing, and all of our frontline staff are doing in incredibly difficult and pressurised circumstances. And then to finish, finally, I did just want to highlight the ICS integrated care system development. The work is ongoing there, and since writing the report, we have learnt of a very important decision around the ICS boundary, which was revealed last week. The new Secretary of State made his decision, and his decision was that there should be no change to the Norfolk and Waveney boundary. And having that certainty is very helpful for planning and for continuity. So those were all the things I wanted to share just by way of introduction. Thank you, Chair. Happy to take any comments or questions.
Great, thanks Melanie for that informative introduction and report. Doris?
Thank you, Melanie, for your report. It's a really good summary. I just have a couple of quick things. One was in relation to the anti-racism or the anti-racist pledge. Should we be sending the link to governing body members so that those who are not on the internal mailing lists could actually make that pledge if they choose to? I would certainly encourage people to do it with my other hat on as equality lead. And I think actually talking about the pressures on the system, I actually got quite a disturbing email from one of our practice managers just before the weekend of some of the abuse that practice staff are getting. And, you know, I accept that sometimes patients could be a bit aggravated because of maybe difficult to get, you know, get through on the phone. But we really should not be taking it out on practice staff. That they're there to provide us with a service. And you know, I just want to take this opportunity to say, we are supporting practice staff, and I would really urge the public to be mindful that they are human beings and they have their families, and they should not be going home from work crying. So that's what I want to say. Thank you.
Thank you, Doris. On those 2 points, on the first point, yes, absolutely. I would like to encourage everybody in the governing body, if you would consider making a pledge to the anti-racism strategy, please do. And we will share details of how to do that after the meeting. And you're absolutely right, Doris. We're seeing a real increase in abuse towards NHS and care staff at the moment, and you know, there is no place to that for that. And I think as well the appalling scenes at the weekend have accelerated some of the tension in the system as well, and we're hearing reports certainly from hospital staff of abuse towards those staff, and there is no place to that. Everyone is trying to do their very, very best.
Thank you. Any other questions or comments on Melanie's report? Tracy?
Yeah, I just wanted to go back to the System Leaders Housing event, which was covered in your report, Melanie, but you didn't have the opportunity because there was so much other stuff to talk about as you gave your update. But just I was actually involved in the Everybody In campaign, and I think the strategic housing partnership, working with district colleagues, housing providers, become a real kind of forum of how an ICS system can work together to absolutely address inequality. So really commend the work that's taking place there. So pleased that you supported that and you found the day useful. But I do know that certainly, addressing those inclusion health kind of aspects in respect of homelessness is prevention is key, and we know how a safe place to stay, a house, a roof over your head is so important for your long-term health outcomes. So really pleased that you attended that event.
Thank you, Tracy, and yeah, it was a really important event, and I think it's I absolutely agree with you that the focus on housing, not just homelessness but housing generally, is so important, and in keeping with the work of an integrated care system and our values, and ensuring that we switch more to focus on prevention as much as we can. And thanks to you for all the work that you and colleagues have been doing as well over the last 18 months, particularly on the Everybody In campaign, which I know has really accelerated the collaboration and strengthen some of the working relationships which are so important between health, district councils and housing providers and voluntary sector, for example. So yes, it was a really important event.
Okay, thank you. Thank you. Well, thank you very much for that report and discussion, Melanie. Item 7 is for us to receive the annual auditor report. John, do you want to just say a few words about that?
Yes, thank you, Chair. I'll be brief. So this is a core part of the governance process that we undertake each year, which is that the outcome of the annual audit process is presented to a meeting of the governing body in public so that everyone can see and understand the outcome of our year-end process. So it's a standard report that's in front of you today that was reviewed by the audit committee last week, and it confirms the positive outcome of our annual audit process on the 2021 year-end accounts and annual report. As the summary highlights, there was an unqualified audit opinion. There were no matters to report in terms of value for money, which in audit speak is a positive outcome. It's very kind of bland wording, if you like. So it was a positive outcome, and it's here for information for the governing body today.
Okay. Yeah, I see a hand up. I think it's from one of our members of the public, Joe Rust. Did you want to ask a question for clarification on this item?
Yes, I'd appreciate it, please. There are a couple of points that were brought up in the audit about the remuneration disclosures and related party transactions. I wondered when there would be more information about those, but also the most important one to me is that internal audit is outsourced to a third party firm, TIAA, and I wonder how much this costs the taxpayer in relation to internal audit processes, for example, at local councils where they have an audit panel.
Okay, thank you. John, are you able to answer that today, or?
We'll perhaps come back in terms of the costs of the internal audit function. Not quite sure what the specific questions were, I suppose, in respect to the remuneration report related party transactions, but maybe we could clarify those offline.
I'm happy to explain. The audit said that there were the remuneration disclosures weren't fully there, you know, and that they should be. And also, sorry, I did have another one. It was relating to the CCG achieved a surplus of £0.6 million, therefore delivering the statutory duty to break even. This is on page 52. The NHS England provided top-up funding to cover any additional reasonable costs incurred. I wondered what criteria are there to stipulate what NHS England considers reasonable, and what the situation would have been had NHS England not considered them reasonable and the CCG not broken even. Thank you for allowing me to put that second question.
Okay. I'll ask you, John, as much as you can to respond to that. But I would just make the point that that we have a statutory duty to break even, and it's and you'll tell us what our budget is. But I know it's over £1 billion, and actually, you know, £1 million is less than 0.1% of that. So there's always going to be not an exact amount that you end the year on. John, would you like to respond?
Absolutely, thank you. So on that point, and we spend best part of £2 billion on an annual basis. So as you say, it's a fraction of a percentage was that's surplus at the end of the year. In terms of the assessment of the top-ups, the regime was that NHS England calculated nationally based on previous costs of the systems what the top-up should be. So it wasn't as if we had to submit information, if you like, to apply for those top-ups. They were calculated nationally. Apart from certain COVID-related expenditure for things like the hospital discharge programme, where we did submit submissions for cost reimbursement, and they were subject to an audit actually, which we received a favourable opinion on. In terms of the remuneration report and related party transactions, I think the report is just referring to the fact that a normal part of the annual audit process is that auditors go through in some detail those particular elements. There were one or two elements of detail that they picked up along the way, and we did make all the adjustments that the auditors requested. And therefore the final version of the remuneration report and the related party transactions disclosure in the documents that are on our website do show the fully audited version. So there's no further information to come out on those, but the report just reflects the fact that auditors commented along the way to help us to make sure that what was the final version was the correct version.
Thank you.
Okay, thank you. Thanks, John, for answering those questions comprehensively. And we're asked to receive the report for information. Are there any other comments people want to make on the report? No. Okay, great. Thank you. So we'll move to item 8, which I think is a really important item because it relates really to what our kind of priorities are for this coming year. And Andrew and Anna are going to go through how the national priorities that have been set for us translate into what that means for us and our specific priorities.
Thank you, Chair. I'll make a start with this and hopefully I can be brief so we can spend a bit of time talking about the values, because governing body have seen the priorities a couple of times now. So the 6 national planning priorities, we agreed that we would turn them into a narrative statement so that we could be much clearer about what the outcomes were, what we were trying to achieve, and that it would make more sense to our staff, our patients and our stakeholders. So with some excellent support from governing body members, some good contributions, we've produced this final version that you've got for approval today. I think the only thing I would just add to this is that we will just need to look at the more detailed planning to take these forward in the context of half 2 as we move forward. So there may be changes in national priority or national guidance. And of course, there'll be some changes in terms of the financial efficiency expectations for the second half of the year. So we will just have that in the back of our minds from a detailed planning point of view. But I'm pleased to present them today for approval as included in the paper, and happy to take any comments or questions.
Okay, thank you. And Anna, did you want to add anything to that?
Yes, is it okay if I just cover what's in my paper? So my paper really is here to ask the governing body members to endorse the values of inclusive, respectful and innovative as chosen by our staff. Once the governing body has endorsed these values, we'll be able to bring them to life in the work that we do to develop a behaviour framework, cascade them through the appraisal process, use them in our communications and in our conversations with staff. So we'll be arranging a lot more engagement on the values really to bring them to life, and they will really set the way forward in terms of our culture, attitudes and behaviours. So delighted to bring them here today. I think it's a really important piece of work.
Yeah, no, thanks, and then thanks for being so gracious in not pointing out that there are 2 separate papers under 8, and that perhaps we should have had a discussion about the first item before going to yours. I've got Tracy on my screen. Tracy, did you want to ask a question either about the priorities or the values? We'll take them together.
Yeah, it's kind of a statement almost, but I just felt with the priorities, we did spend time engaging with, the CCG's team, the executive and the governing body. So I felt where we came with our statements was really reflecting on our kind of mark on what the national priorities are, so they reflected for our system. And Andrew, just keen to hear, you said obviously going forwards as we're now moving through statute and we will change into ICS, that we will reflect and potentially revisit those as priorities might change. So I suppose at the moment there's no timescale for that, but it's something that we're keeping an eye on the national guidance, I would imagine.
Yeah, Tracy, that's right. So for us, it's important that we've got priorities that are meaningful for our staff. And I think I would hope that people will identify with these and they would relate to their day job, if you want to think of it that way. And these are things that we're trying to do. So notwithstanding changes in guidance and what might happen as we move towards ICS, these feel like the right things for our population. So I'd hope that these would certainly survive that. Certainly there'll be an opportunity to look at how these potentially expand into being priorities for the wider system. And again, you'll see things in there that will be absolutely front and centre in our providers, our local authorities, papers and all their board documents as well. So I think hopefully we've got a good set that will certainly carry through at least the rest of this year, and then we can review post April 22.
Okay, thank you. Joe, Russ, I can see your hand is up. Is this relating to one of these items that you wanted to ask?
I'm usually pretty good at putting my hand down once I've asked. It was regarding the CCG priorities, and obviously nobody would want to disagree with them. They look good. But my question was relating to priority number 3, to make Norfolk and Waveney the best place to work in health and care. Having the best staff and supporting them to work well together will improve the working lives of our staff and means people get high quality, personalised and compassionate care. But obviously in King's Lynn, bearing in mind whether this relates specifically to CCG staff or the wider CCG system, as has just been said, how they'll expand into priorities for the wider system. If we look at the Queen Elizabeth Hospital and any staff working there, whether they be specifically CCG staff or local government or, you know, whatever, currently the Queen Elizabeth Hospital isn't the best place to work. And now I appreciate we're all waiting for news of funding, whether we get a new build or a phased rebuild, but how will the priorities match what happens if we don't get the level of funding we need to make those improvements for, you know, as I said, both CCG staff and then those wider system staff? Thank you.
Okay, thank you. I mean, that's quite a complicated question. I don't know who wants to.
Chair, if I may, it might be helpful just to ask Anna to say a few words about the way the system is coming together around the workforce and some of the work that we're doing there, which may help address the question.
Thank you. Joe, we do have a strategy. It's called our We Care Together People Plan, and it's very comprehensive, and it sets out a number of actions that we're going to take to make Norfolk and Waveney the best place to work, and that's for all of our workforce across health and social care, and it was developed, you know, over a long time with lots of engagement from staff. The Queen Elizabeth are key representatives on lots of our workforce groups, and are with us on this journey, just like everyone else, to implement a number of ways to do this. So very comprehensive, from thinking about staff wellbeing to how we develop a pipeline of people that can come into health and care careers, get excellent training and support, as well as what we're doing to pay attention to develop the culture in our ICS. So that's just really a high line of how we're tending to do it. So it's very much embedded in our strategy, in our system.
Great, thank you. Can I just check, Mark Jeffries, did you want to make a comment, or did I
I did have my hand up, I knew, but the question was largely answered by Andrew's reply to Tracy. Thank you.
Okay, great, thank you. Claire?
Thank you, Chair. Again, I think it's a good document. I do have to say I think it's slightly aspirational, but I think having aspiration is good, and we all have to have something to aim for, and I think that's actually very important. The one thing I would really like to see greater emphasis on as we work to system, and when this document effectively is reviewed for us to work as a system, is that attention to those wider determinants of health that we've already mentioned on a number of occasions in this meeting. So I think that's important, both in terms of the health of our local population, but also in terms of the health and welfare of our workforce. And when we think about the reasons why someone would want to come and live and work in Norfolk and Waveney, obviously having a good job with a good employer in a nice place to work, in a place that's very rewarding to work, where you're made to feel welcome, is very, very important. But so too is access to other things like affordable housing, nice places to live, good transport and things like that. So it's really important that when we think both about our workforce and how we can develop that for the future and achieve some of the aspirations set out in the document, and for the health of our population, that we really are thinking not just about health, but very much focusing on those wider determinants of health, not all of which we can impact, but where we can, it's important that we are making efforts to ensure that we do impact those where that's possible.
Thank you, Claire. I don't have anything to add to that other than in support. I don't make apologies for the ambition of the priorities, as you would imagine. But I think in terms of your last point there, for me, as we transition into the wider health and care partnership, then that's front and centre in terms of our ambition there. So it links with the work that Howard does, it links with the work that you're involved in on the inequalities. But I think the opportunity through the health and care partnership to attack those challenges that you've referred to will form a major part of our system work. And indeed, some of the work that we've put into our 21-22 plan does talk about that. And of course, our role in the public sector as anchor institutions will feature in there as well. So we've got a duty. We'd want to do it anyway, of course, but we'll absolutely be making sure that we take that forward with our local authority partners together. So watch this space on that one.
Okay, great. Thank you for that. So, so I've heard quite a few supportive statements. Can I ask the governing body to approve those priorities then for this year for the CCG for 21-22? Yeah, and then also for the values, we're asked to endorse the values for the CCG as they're set out. So I can ask you to approve those or endorse those values. Yeah. Thank you. Thank you very much for that, Andrew and Anna. And so let's move on to item 9, which is an update really on something that we and the CCG and the governing body wanted an update on, which is of great concern to all of us, to make sure that as we come out of the pandemic, that we get services, particularly our elective services, back to recovery, and we're aware of the waiting list. So Mark's produced the elective recovery report, which sets out what the plan is, what the figures are for the coming months. So Mark, do you want to introduce the item?
Thank you, Chair. So I'll take the report as read, and also I'll take as read the background information to the report, which was presented at the May 2021 governing body meeting, which explains some of the previous arrangements, between Wave 1 and the present arrangements. So since the last meeting, we've established an elective care recovery board, which is chaired by Caroline Shaw, who's the chief executive of Queen Elizabeth Hospital. And we've also strengthened some of the arrangements in relation to the work streams. So we now have 6 work streams, which is 3 led by medical directors. So that's clinical harm and harm reviews, future models of care and diagnostics, and 3 work streams led by the chief operating officers. So that's single patient waiting lists, performance, and theatres and inpatient capacity. And I personally lead the outpatient transformation work stream. So obviously there's quite a lot there in those work streams, and each of those work streams provides a highlight report to the elective care recovery board, which meets every 2 weeks and has so far met 3 times as well. So I think it's been a very positive development for the system. There are certain sort of policies and procedures which we managed to get agreed relatively quickly, and I've given a highlight of some of those in the report. So, for example, I think it's been discussed for years perhaps, so potentially having a single patient waiting list, but we do now have a sort of draft SOP that's been worked up for having a single patient waiting list for urology and for endoscopy. We also have got some unified policy in relation to, for example, patients who are on the waiting list and have received their prioritization coding following the requirement to actually do that prior to November 2020, and we've agreed a set of criteria as to when those patients should potentially be re-reviewed based on the initial P coding and also the clinical condition that they're coming in with. I think one benefit of broadening the scope into outpatient transformation, from my perspective, is I've been able to see that there are some differences in relation to the uptake of particular kinds of outpatient transformation. So, as an example, the Norfolk and NHS have patient-initiated follow-up for 29 different specialties, but they're now at 5 specialties at the James Paget and 3 at the Queen Elizabeth Hospital, and these haven't occurred as a result of any deliberate attempt to deviate from each other. It's just that these schemes have gone in and they've worked relatively independently to implement them. So one of the key parts of the work stream is just to bring these trusts and level them up in terms of what we're doing in relation to these programs. So I'll leave it there, and I'll invite questions. But overall, I think the arrangements have strengthened the grip that we've got and visibility we've got on what's happening in relation to elective care. And I've also got to hand the papers from each of the individual work streams, so we're very happy to answer any specific questions on one of the work streams if people wish to ask it. Thank you.
Okay, thank you. Tracy.
Yes, thank you for the update, Mark. And it's really good to hear that the work streams are in progress and kind of the supporting governance now around kind of that elective work recovery. Just in respect of the clinical prioritisation and harm reviews, are there any kind of identified trends that are coming out of those, and anything where we kind of really need to take some action upon? And then secondly to that, just interested in some of the clinical variation between some of the providers, and just really what are there any real challenges in respect of that as well? And clearly I'm sure that where there is good practice, that's being shared and kind of, you know, integrated across the system, but interested to know what some of those challenges are as well.
Thank you, Tracy. So you know, in terms of the harm review and the prioritisation, yes, I think there's, you know, there is some significant concern about patients of deconditioning on the pathway, and I think that's that will probably be, you know, the number one thing that people are concerned about at the moment. So so as a result of that, there are triggers for patients to be re-reviewed after they've received their initial code. So they're currently in draft format, but we do have a draft that's been agreed at the Elective Care Recovery Board, and is currently with the teams to operationalise exactly how that would work. So so in the short term, it is a re-review, but as mentioned in the later paper from the clinical executive, we are also looking to explore whether or not there might be a community element to checking to see if those patients have potentially deconditioned whilst they're on the pathway. In terms of challenges, in terms of clinical variation, I don't think they've arisen as a result of very different opinions between the clinicians. I've found the clinicians to be on the whole, but not universally, in agreement where clinical matters are concerned. I mean, there are particular technological issues which have hampered some of the equal rollout, and I think the most significant is just in relation to some of the difficulties that Norfolk and Orange consultants have in relation to reviewing their advice and guidance. So my understanding from speaking to Ed Snelling, who's their Chief Clinical Information Officer, is that in order to access that system, they do actually have to separately log out from whatever system they're using and use their smart card to log into that other system. So that has meant that that compared to, say, the James Paget and the Queen Elizabeth Hospital, they have fewer referral assessment services, which are essentially sort of single points of access for both advice and guidance referral. And those are commonplace across many specialties in James Paget and the Queen Elizabeth Hospital, but less so in the Norfolk and Norwich. And secondly, there's also because of that, there's also slightly less coverage in terms of specialties at the Norfolk and Norwich. So in particular, there is not orthopedic advice and guidance at the Norfolk and Norwich, and there is inferior cardiology guidance, but you know, there's a sort of auto response whereby they go back to the GP's advice to effectively call another number in order to get that response. Some central Norfolk GPs have also expressed with frustration with the radiology advice and guidance as well, which Hilary and I are taking up separately with the operational leads. So I would say that's the biggest source of variation, but I'm very happy to answer any questions on any other variations that you would like me to comment on.
Okay, thank you. Mark?
Thank you, Chair, and thanks, Mark, for the paper. You've referred to the single waiting list in endoscopy and urology. Are you able to share with us which other specialties are being prioritised for single waiting lists?
I can't off the top of my head, Mark, sorry, but I'll share that with you separately if that's okay. Thank you.
Thanks.
Okay, and can I just ask a question about as well, just in terms of the single waiting list? I presume that's single waiting list across the trusts, and I just wanted to check whether thought's been given in terms of patient choice, because I know that that's been sort of one of the sort of things that patients have got a right to ask where they're referred, and whether this relates to the current waiting list, but does it also refer to new referrals? Is the intention that patients will be referred to a common system across Norfolk and Waveney, or will they still have a choice of where they're seen and who they're seen by?
Yeah, so it's a slightly complicated situation in relation to endoscopy and urology, because, you know, in theory, constitutionally, patients who do have cancers, their rights in terms of choice are a bit more limited relative to those entirely undergoing elective procedure. So, the intention is to offer that choice where it's appropriate and not thought to be cancer related. I think how we operationalize that is still something that we need to work out, because one of the issues would be is that if a patient is seen at a hospital for an initial investigation, which is different from the local hospital, if they do require some ongoing treatment as a result of that, how will that work? So I think for us, that's the major bit that we still need to figure out in terms of implementing that policy.
Yeah, no, and I think that's just the sort of discussion you need to have, and in relation to continuity as well, where patients have previously had a relationship or service from a particular provider or specialist, that where possible continuity should be there as well. Claire?
That was exactly going to be my question, as to what extent did we, I'm sure it's a very useful way to provide a service for very many people, but I think there is just a risk that actually it won't be something that everyone can uptake. I'm thinking particularly about older, frailer people, or people who have transport difficulties, who live remote from the place that treatment might be accessed more rapidly. And similar questions about continuity of clinical care. So we've talked a little bit about moving patients around the system. Are we doing any work to move workforce around the system, which would be the other way to do it, and potentially make life a bit easier for the people who we're looking after?
So you want to answer that question? I was then thinking, do you mean moving them other than through electric wires?
Yes, so physically. So, you know, somebody from, I know we do that for some specialties to a certain extent. So it's whether that work had expanded. So rather than me having to send someone who perhaps is frail and has transport difficulties all the way from West Norfolk to the NNUH or the GP, if we've got more manpower and more, I mean, I suppose a lot of the time it'd be estates that perhaps limit throughput of workload rather than people, but where people might be seen as the limiting factor, whether we're moving members of our workforce around.
Mark, do you want to give Claire a proper answer rather than mine?
Yeah, no, I think I think that's a very legitimate challenge there. So I think I'm sure the acute hospitals won't mind me saying that it's not the default thing at the moment that the clinicians move to follow the patient, and I think that was obviously one of the sort of significant drivers behind the acute service integration piece for ENT and for urology as well. So I think one of the discussions we're having, particularly in relation to dermatology, for which I do have a very specific work stream doing, given its the unusual nature of the problems and its prominence in terms of its place in terms of performance on the waiting list, is that we sort of have explicitly said as part of that is that now that we're actually using remote forms of triage and reviewing referrals, that really, you know, the clinical workforce should be united at the very least in terms of that incoming referral and assessment of that incoming referral. So even if you can't necessarily physically move in order to actually undertake a session here or there, that at the very least you could, by having an economy of scale, then perhaps somewhere like the Queen Elizabeth Hospital, where they only have 1 point something consultant perhaps don't have a consultant of the day to take in a triage. If you combine the forces of the dermatologist at the Norfolk and the Judith Paget, then you could actually form a rota which actually did get those initial triages, referrals triaged, on a rota basis, and then that could be planned. So I think that's probably going to be something that we will make more immediate progress on than the actual here's your car park and please go to theatre 12, as it were.
Okay, Claire, is that your hand still up?
Yes, I just wanted to come back in, if I may. So I think I know there's a lot of really good work going on across the system, but I think it is an area that would be worth perhaps mapping, because we do have quite significant differences in manpower at the 3 different hospitals, and there may be specific specialties where doing something like that, a little bit of outreach work which isn't yet established, would actually make a significant difference to that particular specialty. So I just wonder if that's something we could perhaps plan to explore in the future.
Thanks, Claire. So I think we could very easily do a fair baseline piece of work based on the e-referral system data. Obviously, to do a total census across all specialties is going to be fairly time consuming. But what I could do is I could ask my colleague Lizaire to see if there's, based on the referral data, whether there's any sort of early warning signs in terms of discrepancies and waiting times across the area, to potentially target particular specialties for a question such as what you pose.
Okay, great, thank you. No further questions or comments. I'll thank Mark for that elective cover report, and move to item 10, which is to look at the system pressures that are being faced in Norfolk and Waveney, and Mark Burgess is going to give us an update with others on that, including the rates of COVID-19, which obviously is of concern to all of us. So, Mark, do you want to start this discussion, please?
Anouk, if that's okay, it's Jossie. I'm gonna start first, and then I'll hand over to Mark. Sorry for the confusion. Just really, myself and Mark are just going to give you an update on the current pressures facing our system. And I mean, it's not unsurprising that our system remains under pressure and is excessively busy. We've got a high number of people accessing our services. The number of cases of COVID in our system does remain below the national average and also the regional average. So that's fantastic, but we have seen an increase locally just over the past month. Before I hand over to Mark, the figures that you've got in the report there to the 10th of July, I wondered if it just might be helpful just to give you some slightly more updated figures, for no other reason than when we wrote the report, they were for submission, they were the figures at the time. So I'll sort of very quickly rattle through some figures. So nationally, to the 26th of July, we've got 252,875 positive cases over the last 7 days. 88.1% of all adults have been vaccinated first dose, and 70.5% of adults have been vaccinated second dose. Specifically for our system, the Norfolk rolling 7-day average to the 21st of September is 327. That's down on the rolling 7-day average to the 20th of July at 350. So again, don't want to get excited, but luckily the figures are heading in the right direction. As of the 25th of July, we've got 44 patients in hospital and 8 patients in critical care. So that number, certainly in terms of people going into ICU, is on the up. We've got 19 open outbreaks across our care providers, 17 open outbreaks across our businesses and workplaces, 28 open outbreaks across our education settings, and 3 open outbreaks across health and emergency settings. And just for clarity, an open outbreak is classed as anything with 2 or more cases. So whilst any number is still too high, I don't want people to panic and think we're sort of, we're massively an outlier, because we're not. Just in terms of East Suffolk, the 7-day rolling average incident rate to the 21st is 251. And again, that's a slight reduction on the 7-day average to the 20th of 265. So that's good. To the 21st, there are 555 Positive cases in the last 7 days in East Suffolk, 13 outbreaks in care homes and 14 outbreaks in our day services. As I say, I've sort of thrown a load of new figures at you. I will capture them in the minutes really, but it was just to give you an up-to-date position on our numbers. I will hand over to Mark and then obviously very happy to take questions on the back of that. Thank you, Chair. Mark, all yours.
Thank you, Jocelyn. Good afternoon, everybody. And again, I think conscious of time, I'll be very brief so we can spend the time on questions and discussion. But 3 things I would like to add really, and taking the paper as read. Firstly, to say around the system pressures, these are not Norfolk and Waveney problems alone. A lot of these pressures that are there in the report, speaking with colleagues regionally and nationally, are being experienced elsewhere. The second thing, building on Melanie's point earlier in her report, those pressures, those systems pressures are having a real impact on staff. That's both within the providers, but also actually to flag on our teams as well within the CCG, that pressure is beginning to show. So it's really important that we continue to support our staff at these challenging times. And then thirdly, I think what is pleasing to note is that despite these pressures, in the vast majority of cases, it's really pleasing, encouraging and good to see that all staff, providers, teams, both CCG teams and providers are working extremely well together in RI across the ICS to try and address some of these challenges. Just to drop a few examples, for example, the pressure that we're seeing in and around urgent emergency care, primary care, are now in discussions with all 3 acutes about what can we do to support those pressures at the front door of the hospital. We know that the mental health trusts are now engaged with primary care around those practitioners supporting mental health services in primary care. So absolutely those pressures are there, and there are a number of schemes that we're working on and looking to put in place to try and support. I won't mention elective because Mark, I think you've done that already. But yeah, pressures are absolutely there, but it's pleasing to note the way that people are trying to address those and support the people of Norfolk and Waveney. But very happy to take questions.
Okay, thank you, Jocelyn and Mark. Any questions or comments on the report? Okay, can't see any hands up. Great. Well, thank you for that. You obviously answered all the questions that were potentially going to be asked, so well done on that. We'll take that as a compliment. And move on to the next item, which is 11, and an update on the next phase of vaccination, the booster vaccination plan, which we wanted to know what the latest intelligence is on that. And Howard, are you there to give us an update on from your report?
I am, yes, thank you, Chair.
Yeah.
So I will take the paper as read and just pick up some key highlights and updates. Before I start, it's probably worth reiterating once again what an absolutely superb achievement the COVID vaccine delivery has been for Norfolk and Waveney. We currently have delivered about 1.4 million doses of the vaccine, with 6 in the country for first doses, 1st in the region for first doses, 4th in the country for second doses, and also 1st in the region for first doses. So we really are, we've done a superb job in Norfolk and Waveney, and hopefully everyone feels very proud about that because it's been a massive team effort. The current modelling work for phase 3 is still underway. We're assuming that we will need to deliver somewhere between 950 to 1.2 million COVID and flu jabs over a 19-week period, commencing from September. The modelling work that we're working on will provide a bit of an evidence base for our optimal delivery model as a combination of large vaccination sites, primary care, community pharmacies and hospital hubs. And we're working with our public health colleagues to support the building in of ease of access, in particular to support the inequalities agenda, bearing in mind everything that we've learned over the course of the last few months. So our future model for phase 3 is likely to be significantly the same model as we've delivered, but probably with fewer large vaccination sites and more small community pharmacies is probably, I think, where we'll end up. We're currently working within the expectations for timelines, but just to highlight, I guess, some of the key deadlines, we were expecting the imminent receipt of the expressions of interest from primary care GPs and community pharmacies. That's due in tomorrow. And then we have to do a prioritization process over the course of the remaining course of this week and next week, including a bit of a gap analysis to see where we might have some issues that might need addressing. And a final decision with NHSE and I needs to be concluded by the 13th of August. The other key thing just to highlight is that we've also gone out to primary care to do a bit of a short survey to see what their key concerns are. And I think I can probably distill that down into 3 key things. One is primary care were quite clear that they wanted a community outreach model, or a hub and spoke, if you like, where the vaccine will come into one place and can be distributed down to a local GP practices. We've discussed this with NHS England, and they're happy with that approach. And actually, it's really what we've been doing anyway over the course of the first 2 phases. The other big thing really is the co-administration of the COVID and flu vaccines, which we're still awaiting for an indication about clinical sign-off. And at the moment, they're just saying late summer. So we don't have any sort of dates, unfortunately, where we can say that. But we have been told to plan on the basis that it will be possible, and that Pfizer will be the COVID vaccine of choice. So we'll be building in things like the 15-minute ops period. It does raise other issues, such as potential disruption to existing and well-known and effective processes for administering the flu vaccine, because delivering flu and COVID are quite different things, particularly if you have a 15-minute ops period. And then the third thing was, of course, workforce was a pretty universal concern, and particularly from primary care about expectations with regards to running this particular program and also BAU at the same time. Happy to take any questions. Hopefully you'll accept this is a bit of a work in progress, but we are working within the accepted timelines at the minute. But the first key imminent priority really is establishing our community pharmacy sites, I think, over the next couple of weeks, really. Thank you.
Okay, thank you. And before I open it up, can I just ask a question about the things we don't know? And you might not have to tell me because we don't know, but the type of vaccine, you said one of the assumptions is that it would be the Pfizer. I presume you mean that they're getting sign-off for administering routinely a different vaccine from the primary 2 that patients received, which I know there were trials going on about the effectiveness of mixing different vaccines, wasn't it?
I think that's another thing awaiting clinical sign-off, Anoop. But in the absence of that sort of knowledge, I guess what they've told us, just for a modelling scenario, is to accept that it'll be either a Pfizer or Moderna type vaccine. So hence the 15-minute ops periods, etc., which is what we need to sort of build into our modelling. But yeah, there is a clinical sign-off still waited out for that, I think, as well.
Okay, great, thank you. Tracy?
Yeah, thank you, Howard, for the update. And obviously we are waiting for that final guidance, aren't we? I think really for me, just reflecting on the previous paper and the system pressures, it's going to be the workforce and the capacity to undertake this programme. It's going to be huge, from all sectors of the workforce, I think. So that's something that I think I'm sure we are thinking about, planning about and working towards that and how we will manage that. The other point, I think it's really good that we're looking at, certainly knowing from being involved in the Vaccines Inequalities Oversight Group, we absolutely could see, certainly in our areas of deprivation and the MSO areas, we could see where the location of those sites really impacted on that vaccine uptake. So really, really, I'm really pleased that we're looking at that and where we're going to have those sites, so it helps people in those areas to access. And just another area that I'm really interested in, certainly we've had good success with the vaccination bus, and certainly from the groups that I work with, those inclusion health groups, really keen that we look at, more kind of bespoke approaches, because, even pharmacy sites, GP practices, whatever, aren't going to be the right places. So it's just incorporating, if we can, some of those kind of bespoke approaches, working with our districts and our voluntary community sector organisations, really to provide that for some of those inclusion health groups. I would like to, have support to do that and continue to do that.
Yeah, just taking them in backwards order, I suppose, Tracy. But you're obviously aware that I'm a big fan of the bus, but obviously it needs to demonstrate, and that's a piece of work we need to do in terms of demonstrating its long-term value, so that's something we're currently working through with NCH&C, and obviously you'll be a key part of that work. I think part of its future success will be, to coin an old adage, I suppose it's the making every contact count. So it's what else can we do while we're in those hard to reach communities that's beyond the vaccines. And totally agree with your point around the community pharmacies. I think that could be a real game changer, I think, for this particular phase, and particularly if we can put some strategically placed community pharmacies in the right parts of Kings Lynn, the right parts of Yarmouth, Thetford, etc., then we'll have built in some of this inequalities work right from the very beginning. So thank you.
Great, thank you. Kathy?
Yes, thank you. Thank you, Howard, for a really interesting update. I just want to go back to the co-administration, really, and just thinking that communication is going to be key. Just thinking about the context now, some quite bonkers myths going around about just one vaccination. So I was just wondering, A, how would we handle that? And B, secondly, I'm guessing giving 2 vaccines at once is going to more than double the time of administration, so it'll make the flow through a little bit slower.
I'm not going to pretend to be an expert on the actual physical delivery of the vaccine, so I'll probably defer to some of the expert colleagues we've got involved in this program. But yeah, I think you've touched on all the things that we absolutely need to think through quite carefully. But NCH&C, who I've also spoken to, they've got a really well-worked, well-versed model to deliver the flu vaccine to staff, for example, and that involves them walking around effectively to staffing it. You can't do that with Pfizer, so that raises all sorts of questions about, we might end up with a model where the flu vaccine could be delivered, say, in a workplace setting for staff, and then we set up special sites where they'll just deliver the COVID vaccine. We'll probably end up with a bit of a hybrid, I would imagine, once we really think this through properly. But yeah, thank you.
Yeah, I'm going to comment on this a little bit as well. I think, in answer to Kathy's question, on the whole, it's going to be a lot more efficient and quicker to administer both vaccines together than to do them on 2 separate occasions with 2 separate appointments and 2 separate sets of vaccinators. The economies are self-evident, and the overlap between groups is huge in terms of those patients who will need both. And the second thing I wanted to say was that I think we should be quite proud of where we've got to with the vaccination program up to date. And I think it's really key that we understand why we've been as successful as we have, and we use that information and knowledge both for the booster campaign, which I think is going to be crucial, but also that we recognise that more than likely this is going to be business as usual for us going forward. Co-administration of flu and probably an annual, maybe biannual, but a regular booster for COVID is probably with us for some time. So whatever processes we set up, that they need to be sustainable for the future. And the couple of things that I think are really important are that the workforce, we use the workforce we've got, particularly we've got a new cohort of vaccinators and volunteers who've stepped up to the mark, and actually we need to encourage them, support them, pay them as well, because some of them have just worked for free because it's the right thing to do. But actually for the future, that might not be sustainable. It's crucial that we maintain that enthusiasm from those particularly returners that previously haven't been part of the workforce. And finally, I think Tracy's point about the hard to reach as well. I think one of our successes has been that we've been innovative about how we've gone out to groups. And I think if we can continue that in the future, including for the flu vaccines, actually that will have a huge impact on patients that previously we've found really difficult to reach. And I think for the future, that needs to be every year rather than just identifying it as a need for COVID. Thank you. Karen, is that your hand up there?
Yes, it just had a point from Rob Bennett, Chair, who had to leave the meeting. He wanted to ask Howard, have we captured the key learning points from phases 1 and 2, and are we applying these lessons to phase 3?
I think it's fair to say we're still in the process of capturing. There's so many actions, Karen, that have happened over the course of the last few months, but so we're in the process of capturing that. I think one of the key things, really, one of the key determinants, I think, of success in Norfolk and Waveney has been the ease of access that people have had. So at the primary care level, so I think we've had the right combination, the right delivery mix, and so that's probably one of the key things that we just need to make sure we're getting right from the very beginning. But we'll continue to build that learning, and Anoop's point around this phase 3, making sure it's kind of future proofed and ready for future, I think is also spot on, actually.
Okay, great. Well, thanks very much, Howard, for that update. And I'm sure we'll be wanting, and I'm sure you'll be wanting to give us that updates as we go through the remainder of the year. So thank you for that. I think it's probably quite timely for us, perhaps just to take a very short comfort break for 5 minutes. I'll ask you not to necessarily sign out of the meeting. Perhaps if you switch your computer, your videos and microphones off, and if we rejoin in 5 minutes time, we'll have the remainder of the meeting then. Thank you. Okay, welcome back, everybody. Oh, thanks, Jane. I can see everybody now. Okay, let's carry on then. So I think we were on to item 12, which is the annual report for Norfolk and Waveney on learning disability mortality, the review for 2021. And Kath, do you want to just give us a brief background to that report and the salient points, please? Thank you.
Thank you. So the reviews of lives and deaths of people with a learning disability is a programme now in its 5th year, with the aim of identifying reasons why people with a learning disability die at a younger age, and the aim is to have a positive impact on the health and social care service delivery. I think a really key point, which is it's so important that we recognise, is that people with a learning disability have between 15 to 20 year reduced life expectancy than other people. And the Norfolk and Waveney median age of death in 2021 was 61 years, and actually 62 years old nationally. Recognising that last year was a very challenging year, significant progress was made with the reviews. And we've identified learning points which are set out in the report. We've also set out some priorities for the year, including making sure the new policy and national policy is put in place with a view of improving and enhancing the programme, and including people with autism in that programme as well. Finally, before I hand back, I think it's important that we recognise and thank the co-chair to the leader programme board, who is a person, Andrew Borrett, who's a person with who's an expert with lived experience of learning disability and autism. Also want to point out and commend the production of an excellent easy read version of the annual report aimed at the population of people with a learning disability or people with autism. It's really important to reinforce the importance of the fact that there are such significant health inequalities that are experienced by people with a learning disability or autistic people, and that we have a system-wide commitment to increasing the level of reasonable adjustments in recognition of the health inequalities and lack of accessibility experienced by people with a learning disability or autism. So I think I'll stop there, Chair, hand back, and happy to take any questions or support a discussion.
Great, thanks. Thanks very much, Kath. I think, Kathy, you're first.
Thank you. And I just wanted to confirm that, or endorse what Kath said about, I think there's a number of really good things here in this report. The co-chair, who's an expert by lived experience, the easy read version, all the work that's been done by these people to get through this backlog of reviews. And also, I think, given that the programme's been running for 5 years, the focus on improvement, and it's really beginning to see that we're beginning to see some inroads into trying to reduce the number of deaths rather than just count them and do reviews, really. There were a couple of things that I thought may warrant further investigation going forward, and not for answer now, but I thought the issue that we didn't have any data on people's ethnicity, I thought was a little bit concerning, and I would certainly welcome more information about that in due course. And I think the second thing is the information on quality of care by review on pages 118 to 119. And I wondered whether, is this subjective decision making about the quality of care, or is it based on sort of certain metrics? And if so, would it be helpful to, in due course, look at the proportion of cases that have good care and the proportion of cases that have bad care, so that we could possibly draw some conclusions about whether care is improving or not going forward? Thank you.
Thank you, Kathy. I'll take those back.
Yeah, thank you. Doris?
Thank you. Thank you for the report. And it's always interesting to read the annual report. It was just a question. There was a couple of references within the report about working with Norfolk Safeguarding Board. I would very much hope that we're doing the same thing with Suffolk, seeing that we cover Norfolk and Waveney. So just plea, it might be just left out in the editing, but we mustn't forget our Suffolk colleagues. Thank you.
Thank you, Doris. No, it very much is with Suffolk as well, and I think that's an omission rather than a lack of engagement with Suffolk.
Okay, Claire.
Again, thank you, and thank you for the report. I just wanted to ask a couple of sort of interlinked questions, if that would be okay, just from my recent working with the Vaccine Inequalities Group and trying to ensure in-reach into people with learning disability and autism. About the different teams. We've got a number of different teams who are involved in caring for people with learning disabilities, who have access to different clinical systems as well, which don't always link with a clinical record. So I was just wondering, in terms of work to ensure we've got equity, both in terms of ensuring that people with learning disability are looked after, proactively looked after in a way that meets their needs, but also ensuring that we've got the same standard set across the whole patch, and that we're able to support clinicians to do their job as well as they can by improving access to records, and what work was ongoing really to kind of address that.
Absolutely. So I think the first thing is the community teams that are provided by NCH&C have access to System 1 as the clinical record, but recognise that there are teams that work in secondary care that won't have the same level of access. So I think it's a really important point about interoperability and access of clinical records, and may well be an area in which is exacerbating those inequalities and lack of continuity. So I would be very happy to take that point back and ask that feeds into the improvement plan and into the ICS digital infrastructure for supporting that area. Thanks, Claire.
Okay, thank you. Thanks for those comments and points. Okay, Karen? Is that your hand up, Karen? Accident hand?
No, I think she might have a question from Rob.
Yeah.
All right, okay.
Yeah.
Hi, sorry, my button is unmuted now. Thank you. Yeah, I do have a question for Rob, and it's around the health checks. And he was just wondering what the uptake was on the annual health checks and how we're applying the results of the pilot to increase the level going forward. And apologies, Chair, my internet's not good. We're in a big storm here.
Okay, no worries. Kath?
Sure. So in terms of the annual health checks, it was set out in the paper where we finished at the end of 2021. So the way in which we're measured in terms of the uptake of the annual health check starts on the 1st of April and then resets on the following 1st of April. So we did finish with about 67% completed at the end of March, which was slightly above the standard that the NHS England regional team require from us. So it resets back to 0 on the 1st of April. We don't have data for June, but the data that we have for up to the end of May is 4.44% of the health checks were completed. Important to note that historically, for a number of years, most of the health checks tend to take place in towards the end of Q3 and into Q4. So of those people for this year that have not had their health check, some of them may have only had them 3 months ago. So it is really important that we recognise the 12-monthly cycle and how that will be delivered across the year. In terms of Shepherd Nakubi, working in the primary care team, he's joined Mark's team very recently. He will be leading a programme of oversight, working with the practices with regard to the uptake of the annual health check. In terms of the pilot, which took place in the majority of the Norwich practices, there has been lots of learning. recognising one of the learning points was the inaccuracies of the LD registers within primary care, but also going back to Kathy's earlier point, significant poor recording of some data, particularly ethnicity, and capturing the dates of when they last had their annual health check. So there's a lot of work that's been to be done, that's been exposed as a result of the pilot. And then even more importantly, looking at the quality of the annual health check to make sure that it serves the purpose of why it's taking place, as opposed to it being a checkbox that it's been done and that's it for the next 12 months. So there is a huge amount of work going on in this area. There's still a significant improvement to be made, and I think that continues to be borne out by the learning that's extracted from the leader reviews, but with a system commitment to this going forward, which I think has probably been enhanced and exposed over the last 12 months. This is really our opportunity to take it to the next level and really improve the annual health checks and therefore the outcomes for people with learning disability and people with autism.
Okay, great. Thank you very much for that. Okay, well, we'll move on. Thanks, Kath, for that. And we'll move on to item 13, which is to approve the annual research report. Research is part of our statutory responsibility. Tracy, are you here to give us a summary of the report? And the key?
I am.
Yeah.
Hello there. Yeah, good to see you all. Yeah, it gives me really great pleasure to bring this annual report, which is a 2-year report. We paused it last year because of COVID, but we've brought the data together in line with that duty that the CCG has to promote research. This really showcases the work of the Research Office in supporting UK and local research and increasingly evaluations that we are getting involved with. We've, as always, in recent years, we have done a good mix of case studies to try and make it a bit realer what we do, and hopefully understandably. And I think we've managed that. It really shows the richness of the work in terms of research. Well, this year, what can I say? I mean, despite the 2021 COVID challenges, of course, UK research has been shown at its absolute best, delivering vaccines, preventative treatments to save lives. Absolutely fantastic effort by all concerned. We ourselves help support primary care studies for COVID and indeed the Novavax going through the NNN, where they did manage to have 500 recruits in. And that's the largest vaccine study that's going out across the UK. Really, Norfolk and Waveney has performed at its absolute best this year with 8,000 patients taken into trials, and we were the top national area on the league tables. I think really down to the experience and commitment of our practice teams over many years, they were able to juggle this with absolutely everything else that they were doing. Massive thank you to the patients who get and public who get selflessly involved. Without them, none of it possible. So another thank you to the delivery teams at the community and the CHNC that have the primary and community teams. Fantastic work by them and lots of agility in picking up studies that were going to be suitable for this quite difficult year. Unprecedented development this year, research with academic partners as they all were at home trying to meet the government calls that were coming out for COVID. And we had 28 CCG lead applications with us going in, which we've never had before. And we have achieved 6 grants during this time period, which is about 5 million, so our best year ever. I have to highlight the work of our patient panel that has been a gold standard panel for many years, but this year they worked tirelessly to go virtual, to try and embrace it despite the challenges in their own lives, and really supported COVID research, and there was very, very tight time that we needed to get things in. you know, research is a bit of a long game. I mean, and I kind of know that as much as anybody the time I've been around. With, you know, 10 years to get some programme grants through. I think this year research obviously is going to have, this is going to change everything, isn't it? It's going to have to shift and change with the times, and the government has published best research for best health to try and drive that, and they've got plans to use the learning to expedite things. So really, finally, thank you very much. Thank you to the governing body and the exec team who've supported us over my time as Associate Director of Research. I'll take any questions.
And before we do, I just wanted to thank Tracy, and what she hasn't mentioned is, I mean, she's been involved personally in research and supporting the organisations in Norfolk and Waveney for many years. And I understand, Tracy, that you'll be leaving to retire very soon, so this may be the last meeting. And I just wanted to thank you really on behalf of not just the CCG but the system. I know that your your leadership of the research team has been absolutely marvellous over a number of years, and your commitment to the organisation and to the wider system is really appreciated. On behalf of the governing body, I'd like to really wish you a very happy retirement, and thanks from the CCG for all the what I've seen myself. Your commitment over the years is really very much appreciated. And you're so right, aren't you? Isn't this the year that demonstrates the importance of
Indeed. I wouldn't have chosen this though to go off or out on, but I think, as you say, it has changed absolutely everything. No longer can research say it takes us 10 years to do things, because clearly it doesn't always have to. So yeah, thanks for that, Anu. That's much appreciated. It's been a real pleasure working with many of you as leaders over the last 30 years, actually. For some of you, I'm looking at Kathy.
Yeah. Don't remind us that I've been around for that long.
I've been around. Yeah, thank you very much, Anu. Real pleasure and a real privilege to work in research for the last 14 years. I would say the most rewarding area, or one of the most rewarding areas I've worked in the NHS. So thank you.
Thank you again. And any questions? Mark?
It's not a question, it's an observation, Anu. It struck me on reading the report how fortunate we are to have UEA and its huge commitment to health sciences within the area, and without that, I suspect we'd be in a far weaker position than we are. So all credit there, I thought.
Yeah, absolutely. Good point.
Absolutely.
Okay, well, thank you. If there are no other questions, we'll leave that item. And thanks again, and the best wishes, Tracy. Okay, let's move to item 14, which is part of our regular sort of standing item to review and approve decisions. Oh no, I'm preempting things. It's actually this is a request to approve changes to terms of reference for the IFR drugs and non-drugs panels. And I think Michael's not here today, but Mark, you're going to go through what changes we need to make and ask for our approval.
Thank you, Noob. I'll take the papers as read. There aren't a huge amount of changes. So as some members may remember, we did take a previous joint version of policy to Joint Strategic Commissioning Committee in June 2019, and there are relatively few changes in the policy from then and now. We're now one CCG, so we've changed the membership to reflect the fact that we will have sort of 3 clinical representatives rather than specific representatives from each area. There is an additional feature within the non-drugs IFR policy about sharing the information with the children's team where it relates to a child, just a double safeguard against any medical request that may trigger any safeguarding concerns. We've checked with Russell Clark, our data protection officer, just to ensure that is in keeping with our lawful processing of data entities. And so I think in relation to the IFR policy and the terms of reference, is very much unchanged. In relation to the drugs IFR policy, we have also sort of actively sort of considered whether or not we should bring the number of patients that would require to actually trigger a discussion as to something actually constitute a cohort and needs a commissioning policy, whether or not we should make that 5 in line with the non-drugs IFR policy. But it was felt that because there was a potential for higher ongoing costs, which is the case for many drugs, that we should keep it as being sort of an anticipated 2 patients per year for the drugs policy. So I'd like to recommend the policies in terms of reference for approval to governing body. Thank you.
Okay, thank you, Mark. I mean, quite a few documents there, but as you said, some of the changes are quite minor, and they're just tidying up the changes that have occurred in organisations, as well as being necessary because of guidance and directions. So, any questions, comments, John?
Yeah, thank you, Chair. Just a couple of things, Mark. One is I think there's just a few other bits that just need tidying up in terms of the old CCGs as opposed to the new CCG, but I can flag a few things offline on that. More substantive question was just in terms of the chair of both panels, it just says it should be a member of the governing body. It doesn't clarify whether that's a lay person specifically or whether it's a clinician. I didn't know if there was a particular approach that we were taking.
Yes, John, I think on the whole, it has tended to be a lay chair. So I think the previous chair prior to the CCG merger was Carl Fenlon, and I think it's more common in for it to be a lay chair. But obviously we recognise that there may be capacity issues in terms of specific members being able to undertake this role. So I've left it as being governing body member for the time being, just until we're able to agree with Karen that it should be a particular lay member or clinical non-exec director or whomever it should be. Thank you.
Okay, Claire.
Thank you, Chair. And again, thank you for the papers, Mark. My question is a sort of related, but not a question that's directly related to the papers. I think you raised a really important point about if the same thing came to the IFR panel again and again and again, it implies we've got a commissioning gap. And actually potentially it's a pathway by which we will identify unmet clinical need. So just with that in mind, as part of the group or as a work developing from that, is there a plan or do we currently have an accelerated pathway to review and commission where we identify an unmet clinical need as a consequence of things becoming recurrently to the IFR panel?
Yes, I think that the trigger for that would be 5 patients, but clearly we use our common sense that if it's the first one and we think that's going to be a recurring theme, then obviously then we will take it from there. So I think for example, there are a couple of IVF requests which probably fall into that category, for example, which require a commissioning decision of that sort, and you're aware that we're in discussions around that. There isn't, as it were, a separate panel which it goes to. So what I would normally do is I would normally pick that up directly from the IFR meeting and put it into the clinical policies development meeting, which occurs later in the same afternoon. So essentially, we would, if a panel has identified something in the morning, then in the lunchtime CPDG meeting would say, we saw this case this morning and this needs a policy. And then myself and my team would just pick that up. And then it would probably, if it was a matter of a clinical threshold, such as there's an IFR for something that may affect the threshold, then it would stay within the CPDG as being a policy for the group to change potentially. But if it was actually a commissioning gap type of thing, what will happen is that we would keep a note of the commissioning gap on the action log of the CPDG, but it would obviously go to places such as clinical exec for the actual commissioning decision.
I just wonder, I mean, I think that's a really good explanation. I wonder if it'd be worth just actually capturing that in the policy itself, so that actually those who are involved in running the the IFR panel actually know exactly what action to take when they encounter that eventuality.
Yeah, no, that's a very good point, Claire. We'll add a paragraph to explain that. Thank you.
Okay, thank you. That's a good point. Any other questions or comments before we ask you to approve those changes to terms of reference and policies? No? Okay, so can I ask the governing body to do so then, to approve those changes to terms of reference and policies?
Are we able to document with that caveat that paragraph will be added?
Okay. So yeah, we'll do that. Thank you. Item 15 then is to review recommendations which have been made to the Drugs and from the Drugs and Therapeutics Committee. And again, I think Michael's not here today, so who is it yourself, Mark, that's going to ask for that to be taken?
Yes, I'm happy to take the item, Anoop. We were expecting that member of the team to phone in, but we are slightly early. So, these recommendations have been through the Drugs and Therapeutic Committee and clinical exec. So I'd like to present them to governing body for approval. Thank you.
Okay. Yeah, and I can confirm they came to the clinical exec, and there didn't seem to be any significant issues that were raised. So any questions or comments from anybody? No. Okay. So so having reviewed them, can I ask you to approve those recommendations? Okay, good. Thank you. So let's move on then to the Finance and Corporate Affairs section. And item 16 is to receive a summary of the financial position for this year as it stands currently. John.
Thank you, Chair. So I'll take the report as read, but just a couple of things that I wanted to mention. So just a reminder, we're still in an unusual financial regime because of the impact of COVID. So we have a fixed envelope as a system for 6 months of the year, and that includes elements of topping up to match costs of systems effectively, and also additional funding to support the implications of COVID. Within that environment, the CCG is actually having some pressures in the first 6 months, particularly within continuing healthcare, where the national uplifts to the financial envelopes around continuing healthcare only allowed for growth of about 0.2%, but in reality, price rises, volume rises are well in excess of that, so we are seeing pressure there. So as a CCG, we're £1.6 million overspent after 3 months of the year against that fixed envelope due to CHC pressures, and we've had some good discussions with Kath and her team about investigating some of the things that we think we might be able to do to try and mitigate some of the activity and pricing pressures within that area. In terms of where we think we'll end up at the end of this 6 month period, because just as a reminder, we've only been issued funding allocations and guidance for the first 6 months of this year at the moment. For the period to September, we're saying that we think we will break even against our envelope, but that really will be reliant, we think, on support from system partners. So the health and care system as a whole is showing an underspend after 3 months of the year because there's some slack within providers, which is offsetting the problem that we're showing through continuing healthcare. The expectation is that at the end of this 6 month period, the system as a whole will balance off. So any pressure that we're still seeing on continuing healthcare should be mitigated in the round. The bigger concern, though, is what happens beyond this first half of the year. So the indication is that by middle of September, we should understand what the financial settlement is for the second half of the year, starting from October. And then the planning process for that 6 months will last throughout the autumn. All the indications so far is that the NHS should be expecting to deliver greater levels of efficiency in the second half of this year, and the numbers that we're planning on the basis of are between 3 and 3.5% efficiency. So given that as a system we spend about £1 billion every 6 months, that's in the region of £30–35 million worth of efficiency savings across the CCG and the providers within the system in the second half of the year. So there's going to be a significant increased focus on financial efficiency, productivity, transformation going forwards. because it's not likely to let up either at the end of that 6-month period. The indications are for next year and the following year we should expect significant efficiency requirements. And really, I think that's nationally reflecting the fact that there's been a significant extra amount of money come through to the NHS from the Treasury to support the service during COVID. And this is about getting us back to where we were effectively before that additional top-up funding came through. So the position, the report as it stands, talks about the first 3 months in the context of the first half of the year. But say I'm flagging much more significant challenges ahead, and therefore a particular focus that the CCG and the system will have over the next few months, well, and years probably, will be bringing finance much more back up the agenda. So there's a much more significant focus on that going forward. So I'll stop there and happy obviously to take any questions.
Okay. While we're asking for any comments or questions, I know one of the things that's been in the news in terms of financial pressures are staff cost pressures, and you know, the majority of the NHS cost, and I would say value as well, are its staff, and in the news has been the national sort of uplift to staff from April this year, and the offer that's been increased to 3%, and obviously there's still something, some in the coming weeks we'll know what's actually going to happen. But what's the risk to the system and specifically to the CCG for different assumptions about what the uplift will be for staff for the NHS for this year, and is that a risk that we're managing?
That's a good question, Anoop. So when we were doing our planning for the first 6 months of this year, one of the national planning assumptions was to ignore the impact, if you like, the pay award, because it wasn't concluded at that point. So the expectation is that would be funded separately nationally, because we haven't got anything set aside for it. We haven't been told to plan for it. Having said that, until we actually see the allocation come through clearly and understand whether that matches the cost that we're incurring in the system, we won't know whether there's actually an additional pressure arising from that. So it does remain a risk until that's concluded. But so the expectation, the planning assumption nationally was that this should be covered separately.
Okay, thank you. Any other questions or comments for John on his finance update and report? No. Okay. Well, thanks, John, for that. And obviously that's a running standing item for our meetings, as is item 17, which is to review the governing body assurance framework and the current risks facing the organisation. Karen, do you want to talk to that item and any changes particularly that have occurred since the last meeting?
Thank you, Chair. There aren't any changes to the risks themselves since the last meeting. We have, however, been through the usual process of reviewing this at senior management and exec management team, and all risks have been updated. So it's here for any comments or queries. Thank you, Chair.
Okay, thank you. Any comments or queries on the framework and the risks that are set out? And okay, so Joe Rust, is there a question you want to ask?
Yes, on page 330, it says there's a strategy in place for surveys for critical areas. Sorry, this is in relation to the rack planks, which I'm sure you anticipated me to ask about. And there's a programme for the installation of modular ward areas and theatres. I'm sure that you can imagine, for the people of North West Norfolk who use the Queen Elizabeth Hospital, reference to modular ward areas and theatres would probably be quite concerning. So what reassurances can you give that this isn't going to be some kind of MASH pop-up tent, and what type, of modular ward area are we looking at? Thank you very much.
Thank you. So can anybody ask that question? Or shall we take it away? Yeah, so I think if we're not able to answer the question, Kath, is that you wanted to ask the question?
Yeah, I think I just wanted to add that modular temporary wards are those that are simply not permanent, but they are not of the variety that are like tents or war zones. Some hospitals have modular wards in place for years and years, so they are really very robust and safe, and professionally manufactured by specialist companies, and it's a part of the mitigation plan for the events, not just at King's Lynn, but any RAC plank hospitals within the region or indeed nationally. Thank you.
Okay. Thank you. Hein?
Yeah, thank you, Chair. My points around risk for financial performance. In the Finance Committee, we looked at an equivalent risk, which we moved up in likelihood 1 to the right. So my request is to update the risk visual accordingly, or the risk register, and I think that fits the narrative that John shared with the governing body. Thanks.
Okay, thank you. Any other comments or responses to the comments made? No? Okay. Well, thanks. So we're asked to review. So we've done that. We don't need to approve. So item 18 is an update on the disciplinary policy, which I've got Amanda's name next to it, but I think are you, Karen? Are you
yes, going to present to that? Yeah. So the disciplinary policy is here for approval. We wouldn't normally bring disciplinary policies and HR policies all the way to governing body, but we have been asked by Department of Health to bring this in particular. All trusts and all CCGs in the country have been asked to bring this. They've asked us nationally to review our policy, which we've done, and the proposed CCG amendments are in green. They've also asked us to put in some amended wording, that's national wording, that's in yellow. So it is here along with the letter requesting the ask for governing body approval today, and going forward the audit committee will resume reviewing this. You'll see from the letter we were asked to do this some time ago. We've only just received the request in June from our CSU, so there was a slight muddle there with the communication, but it is now here for the governing body to review. I'm happy to take any questions or comments. Thank you.
Okay, so questions and comments. So some of this has been nationally sort of requested, and there are some actions, aren't there, in terms of, for example, having a welfare officer. Is that something that we will put in place once we've approved, or are we implementing this already?
Yeah, we're starting to look at that at the moment, starting to start that piece of work. It isn't completed yet, but yeah, it's not necessarily dependent on approval. It's a good thing to do, obviously, anyway.
Yeah. Okay. Thank you, Claire.
I just wanted to say, well, firstly, again, thank you for the document, but how much I welcome some of the changes in here. I think there are some really good ideas, and I think it links really, really well with the previously presented papers on our vision for the workforce. So yeah, just to say thank you, and I think the changes are good developments.
Yeah, no, I would agree with that as well. It all makes sense, and actually is good practice anyway. But to put it in writing is good. Tracy.
Yeah, I was echoing what Claire was saying. I think it's good to see this policy, and the changes are really positive ones. I think thinking about, individual staff's kind of health and well-being is key to this, so good changes. Just thinking about, is there implications for training for staff in respect of kind of, this, I know we need the welfare officers, but also there's existing managers training. Is there a need for that, and is that kind of in train?
Yeah, we can look into that. We do already have extensive mandatory training for staff for covering a wide range of topics, for example, listening and freedom to speak up, and a variety of topics. But yeah, we can also have a look to see if there's anything more specific around running these processes. And we're very, very keen as well to train more staff properly in running these processes if we need to.
Okay. Joe Rust, I've got you next as a question. Is that you want to ask? Or?
Yes, thank you very much. It's just a brief one, and please excuse me because I haven't managed to get to this part of the documentation, despite best efforts. Have the trade unions been involved in the changes to the disciplinary policy? As you would expect, they're a key stakeholder representing members of staff. Thank you.
Yeah, good question. Karen, can you answer that?
I believe they have definitely. With the national changes, I think it was all part of a large discussion that prompted this letter in the first place. I'd have to check back with regard to our changes because the CSU have led this on our behalf. I would imagine they have, but I'd have to check that point and come back.
Check that, can't we?
Thank you. If I could make the point, policies shouldn't be changed without the trade union input. So if I would like to put forward that if the trade unions haven't been involved, and you have got trade union full-time officers that represent CCG staff, that they are consulted, as is the legal requirement. Thank you.
Yeah, so we will check if that has happened, and if it hasn't, obviously we'll need to take a considered judgment as to what to do. Okay, great, thank you for that. Doris?
Just to say, I had emailed Amanda outside the meeting just with a few minor suggestions in terms of consistency of language. So if we do approve it, that we're happy to approve, minor editorial changes.
Okay, can you just? I didn't quite understand.
Yeah, that there was a couple in some of the provisions was employees could be accompanied by a fellow employee, and then right at the end it talks about trade union. It was just inconsistent because employees can choose whether they have a colleague to support them or a trade union rep. And I just think we need to be consistent throughout in referencing to things like that, because otherwise you just open yourself up to confusion and challenge.
Okay, so do you want to respond to that, Karen? Because that would.
Yeah, that's fine. That's absolutely fine. I think Doris has emailed those to Amanda, so we'll be able to ensure there's consistency throughout the document in that regard.
Okay, so in terms of approving, will we need to approve subject to those amendments?
Yes, if we approve subject to those amendments, I'll circulate the final copy so that you've all got a copy, and I can also confirm the trade union point raised as well at that point.
Okay, great. Well, in that case, can I ask you to approve subject to those questions being answered and those amendments being made? Okay, great. Thank you very much. Let's move to the reports now from the committees and the clinical executives. I think some of them might have microphones. So just a reminder, if people can switch their microphones off, because I'm getting some feedback. Item 19 is the report from the Quality and Performance Committee, which Kathy, you chair. We have your report.
Thank you, Chair. I'll take the report as read. It's for two committees for June and July, so it covers quite a broad range of topics, and it's for noting by the governing body, please.
Okay. Any questions or comments on Kathy's report? Okay, and next is it's a verbal report from Hein on the Finance Committee.
Yeah, thank you, Chair. So it's a verbal update because the committee meeting takes place on the day the pre-read for this meeting is due. I'll keep it brief. We talked about month 3 results, and as John has alluded to, looked at continuing healthcare, and we'll have a deeper dive on that to look at both the demand and the price pressures on that activity. Transformation planning, we spent quite a bit of time on, and that feeds into the expectation of significant efficiency savings expected in the second half of this financial year and also future years. I think it is important that the government body takes note of that, as John has already provided that information. And John has also made sure executive management team, senior management team, and extended senior leaders are made aware of this coming. And then lastly, we had a first look at the elective recovery fund, both in terms of workings and the contribution in the early months. So more to come in future months. Let me leave it at that. Happy to take any questions.
Okay, thank you. Any questions for Hein on his report that he's given? Okay, thank you. And then report from the Primary Care Committee, which Doris, you chair.
Thank you, Anoop. I take the report as read. It covers June and July, and the team has, upped the work rate to back to more pre-COVID levels. So there's quite a lot of things going on in primary care that is being on the to-do list. So I don't have anything else to add. Thank you.
Okay, thank you. Any questions, comments? Otherwise, then next is a report from Rob, if you're back, Rob, from the Audit Committee. Karen, I think he did give his apologies for this part of the meeting.
Yes, I don't think Robbie's back, but he basically said he was happy to respond to any questions offline if there are any. But the main focus with the meeting was the annual report and the accounts, and the committee's been very appreciative of all the staff input on that topic.
Yeah, okay, thank you. And next we've got, which is a new item, the report from the work of the clinical executive, which includes the governing body clinicians, which I chair, and Mark Lim gives leadership to. And Mark, you've produced a report for the first time on the work of the clinical executive.
Thank you, Chair, and thank you for chairing the meeting for which the committee report refers to. So, as mentioned in the report, we have tried to move away from some of the reactive work of the previous few months to look at some of the service improvements. But the recent announcements in relation to relaxations of social distancing has meant that we've had to discuss whether or not that would apply to healthcare settings in Norfolk and Waveney, in particular GP practices, in our committee meeting. And having had a quite extensive discussion and prepared some communications materials, and done a publicity campaign around that, and literally 24 hours it was announced that would be national policy. So so we were ahead of the curve for once on this, which is pleasing, but obviously it was good to actually have that discussion at clinical executive. We are working on some other schemes which governing body members will note. So in particular, as we mentioned previously in the agenda, schemes to effectively review patients on waiting lists due to the potential for deterioration. We're also undertaking a regular program of review of some of the existing policies and commissioning attention, such as the prescribing quality scheme and the assisted conception policy, which is due for review. But a significant part of the agenda for the next couple of months will be some of the interface work between primary care and our providers, because at the moment there's a wish on all sides for us to structure that debate and come to a very constructive solution, which everybody agrees should be possible in relation to some of the pathway changes which we may wish to keep following COVID, but may involve potentially some parts of the care process being undertaken in a care setting which is different from what they've been previously. Thank you, Chair.
Oh, thank you. And thank you also in your new role of Director of Clinical Transformation for providing support and leadership to that group. So I think that's really been really helpful in recent months. Claire?
Yeah, I just wanted to, I'd echo that, Anoop, and just to say as well that some of it's really important work, and I think really the time is right to kind of capitalise on some of the learning from the pandemic, and it's effectively about working more efficiently and working smarter, for want of a better expression. And I think, that capitalising on that belief that things can change and we can push boundaries and actually do things in a more efficient way, it's really important that we crack on and actually make that happen now rather than defer that. So I think it's very welcomed work. on all fronts, actually, is my impression.
Yeah, no, I totally agree with that. And Mark, did you say for once we're ahead of the curve?
So apologies, that was a mistake. Sorry.
Yeah, no, that's fine. Okay, thank you. Thank you for that report. I think we've got to item 24. So we've had some questions from the public. Have we had any other questions sent prior to the meeting, Karen?
No, Chair, we haven't received any prior to the meeting or any on email during the meeting.
Okay. I can see Richard Chilver's hand up. Thank you, first of all, Richard, for being patient throughout the meeting. So have you got a question to ask? Are you muted by any chance? I can see Richard's hand up, and if you can hear me, Richard, your microphone looks as if it's muted.
Can you hear me now?
Yes, I can. Yep.
Yeah. I'm obviously. I'll make a comment firstly. I'm really concerned that the NHS as a public service is being stretched like a broadband to a breaking point. I mean, the one question that I was a bit concerned about, as you know, in the public zone, there's been this anti-vax campaigning, and I just wonder whether the fact that this is something of concern in the region, and also because obviously it's affecting it's a tax on staff, whether we're hearing that from the public. That's the first question, and I personally think there should be a NHS public campaign to attack this this anti-vax campaigning by the members, by quite a substantial members of the public, because obviously it's going to affect into the future. Second, I do note in these values and priorities, and very laudable in terms of the anti-racist message, the inclusion and innovation. But I'm worried about, and I just wonder whether, in fact, the committee itself is worried about the development of the ICS. It's very holistic in the way you're putting it forward in terms of a whole life concept. But the fact is that we know that the ICS going through Parliament, it's actually driven by centralisation, and also that in fact that it's actually proposing that in fact that the major companies will be put on boards, whether the various 42 ICSs like it or not, and also whether it basically compromise the genuine. I think there's a genuine feeling of integration, of actually joining up services within this person in this way as well. And also a question for John. I mean, I understand that in fact you've only got finance for the next 6 months, and the risk factor. And another question is, of course, is that my understanding that the rush notification about the 3% obviously is of concern, because I think the NHS providers have said they don't know for sure whether in fact it's going to be self-financing, or whether it's going to be new money, or whether it's going to come out of your own budgets. And as John and your audit committee are saying, it looks like it may have to come out of efficiencies. Well, I'm afraid that just not on, and only increase the lack of morale. So I'm wondering whether in fact a board should, I know you may do it behind the scenes through the NHS England, should be making representations to the powers that be, and to government, that this will not be on, but in fact that it'll have to be new money, whatever, whether it's 3% or above. Thank you very much. That's my question.
Thank you, Richard. And I think thank you for that. And obviously you've touched on a number of and you made some points as well. I think the questions relate, and I think we should just try and address those specific questions as I see them. The first one is in relation to anti-vax, and if somebody could respond to that. The second issue, I think it's quite difficult to answer, because it was in relation to the ICS and national changes. and how they impact on us. And I think, you know, we've given an update, and we will give further updates as to our transition from a CCG into an ICS, but some of that is beyond our control. And I think some of the things you were saying, Richard, are more to do with, you know, your belief in national changes in policy, which I think is probably beyond our remit, but somebody may want to respond to that. And the final thing, John, I don't know whether you want to add, but I think you probably answered a lot of that question from my question around the 3% staff. But if there is something you want to add in relation to Richard's point that he's made, then you might want to do that. So can somebody answer to start with the anti-vax issue, particularly in relation to how it's affected the vaccine campaign and whether we need to do anything different in future?
Shall I just try and come in, Anoop?
Yeah.
Just to start. Hi, Richard. It's really good to see you here, and thank you for your excellent questions. I just wanted to just respond. I think the first part around the anti-vax campaign and the abuse to staff. I mean, specifically anti-vax, we have seen isolated incidents, specifically around anti-vax. But I think there is a more concerning trend of abuse that's not related to vaccination towards the NHS and staff. And it is having an impact on morale, very much so, for staff. And we hear that feedback from GP practices, from hospitals, and indeed from our own staff. So, and to some degree, you might think that's not surprising, given all that we've been through as a country and all of the anxiety and frustration there is. But it's not okay, and it's not acceptable to abuse staff who are trying their very best to look after people, and that's both within the NHS, within health services, and within the care sector as well. So I see it much more generally than actual anti-vaccination. Although, as I said, there have been a number of isolated incidents. It's not affecting our vaccination programme, though, significantly. As you heard from Howard, you know, we're doing extremely well there and getting great support from all of our partners, including the police, Norfolk Police, when we need it for those incidents. In terms of the ICS and those national changes and the board, Richard, I see it more positively. I think I don't think that the I think you used the phrase companies, so private companies wouldn't be on the ICS partnership or the NHS ICS board, but other parts of the NHS system would be. I think that's a good thing, because so that includes people like some of the acute trusts, mental health trusts, GP practices, just as now, would all be part of the board, still to be defined, still lots of work to do to define that more carefully. But this is a changing regime. We all our money comes from the same pot. We've previously had arrangements where commissioners sit in one room and trusts sit in another room, but it's all coming out of the same pot. So I think it's a positive development for us all to be around the table together. It's much harder, it's much more challenging, certainly not going to be easy, and it is a change. And I don't know if that's specifically what you're referring to, but on the ICS NHS board, certainly, you know, non-voting members would include colleagues from our trusts. And, you know, here we are at the moment, we have GP practices, you know, around the table here, they're voting members, part of the NHS as well. So I think there's still much work to do, but personal views, I think it's a positive development for the NHS, and that will enable us to give better care for our population in future.
Thank you, Melanie, for that. Certainly agree with a lot of that. John, did you want to mention anything in relation to the financial aspects of the 3% and whether we're going to be given the money centrally, other than what you mentioned already, because I think you gave the response already?
think, as you said, Anoop, we covered a lot of it earlier. I think a couple of extra points I would make. One is that there's nothing to indicate that the two things are linked, that the fact that the pay award is 3% and the efficiency requirement is likely to be 3 to 3.5%. I think the timing for those was different, the processes were different. I think that's coincidence. But as I said earlier, we are expecting additional funding to come through to cover the cost of the pay award. No system, no organisation will have planned to cover that. So there's an expectation that comes through. And in terms of the pressure that Richard alluded to, we have fairly regular webinars with the national team, the national finance team within NHS England, and there was a good healthy debate on the last one a few weeks ago about the balance that there is to be struck between, there's a lot of pressures, huge amount of pressures on the NHS around elective recovery, urgent care, vaccination campaign, dealing with COVID, etc. And then we're talking about ramping up financial efficiency requirements as well. The other side of that is the fact that, for example, we've had about 10% extra one-off funding over the last year or so to deal with extra costs, partly as a result of COVID and partly just extra costs that we had in the system before when we were spending more money than we were allowed to, if you like, by the NHS. So somehow the NHS has to get back into balance, and this is the start of that process.
Yeah, no, thanks. Thank you for that. And just adding to what Melanie was saying, and completely agree with her around the sort of the issues which are broader than just anti-vax. It's about how the public and others, treat our staff, and we really must protect our staff. But I would say we need to do a distinction between the very small number of people that abuse staff or are anti-vax, as opposed to vaccine reticence and people's concerns around vaccines, which I think have been legitimate. And I really want to emphasise the amount of work through the communication teams, through practicing people at the workforce, clinicians, to inform the public, to reassure the public. And it's that work that really I think we should be proud of, and that is why we have had the biggest campaign, the most successful campaign, the vaccination, really in the world. So I think we should be positive about what we've done in terms of how people have engaged with us and been reassured, despite some of the really negative campaigning by anti-vaxxers. Richard, I'm going to allow you to come back just to, if you want to just respond to those questions, but I'd be interested in your kind of reflection on how we've responded.
Yes, fine. There's only one question for John Ingham. What are they going to do? I mean, I noticed that in fact you break even this year, but my understanding is that the finance going forward, you'll have set budgets, and I'm not saying it just for one of the 42 ICS. I mean, what happens in that circumstances where in fact that you can't break even and you're in deficit all the time? I mean, the previous times with the CCGs, they actually their next monies were reduced. If you can't achieve it, then you had reduced money. Then basically CCGs will be made redundant, will be made bankrupt, the ICS will be made bankrupt, and the government will then install their own regime for financing. I just wonder whether in fact that is a danger, really. That's all, in the way that in fact this ICS is developing through Parliament in terms of the control budgets. Thank you.
Okay, thank you.
So just comment briefly on that. So I think if you strip it back, Richard, the new regime financially will be very little different to the old regime, which is that actually the NHS has always had a fixed sum of money to operate within that's given at the highest level by Treasury and then distributed throughout the organisations. I think what will be different going forward is that sum will be fixed for us as a system, and it's then up to the system to live within that, rather than it being the combination of all the individual organisations, if you like, working separately. So that gives us much more opportunity actually to do things on a bigger scale, to drive efficiencies from that, to learn more about good practice across our patch as a whole. And it does open up a whole new opportunity really in terms of trying to get better value for money within the system. So yeah, there will be challenges, of course. There's going to be significant financial challenges going forward, but the advent of the ICS means that we've got new ways, I think, of trying to address that as well.
Okay, great. Thank you for that. So, are there any other questions? No.
No, sorry.
Okay, great, thank you. So we're on the final item. So any other business before we close the meeting? No? Okay, thank you. So a reminder that the next meeting in public is on the Tuesday, the 28th of September, 1:30. Venue and arrangements to be announced. You know, we're hopeful that that perhaps we may be able to hold that in public face to face, but obviously there's a lot of uncertainty around that. But I think we ought to start planning for that, and if possible, I think we should do that. But we'll keep you informed in terms of the practicalities of that and regulation as well, obviously, because we want to maintain safety, obviously, at all times. So I'll close the meeting then. Thank you very much. We have got a second part meeting, and I suggest we commence that at 4 o'clock. So we've got a 15-minute break, and let's reconvene at 4. Thank you very much, everybody, for coming.